Good morning, everybody. Let's continue our discussion in abnormal psychology on the category of anxiety disorders. So, let me get that right here and pull it up here. And whoops, not that. There we go. So, chapter five is covering the category of anxiety disorders and obsessive compulsive and related disorders. Alrighty. The latter groups, diagnosis and related disorders being also very much influenced or driven or motivated by anxiety and fear. Okay, so we're going to be going through each of the diagnoses and their major criteria. And, interspersed, we're going to be talking about the theories underlying the causes of these different disorders, as well as the common treatments. Okay, we're going to just skip that discussion. Maybe we might come back to it at some later point about mass shootings. But let's focus on the chapter discussion. So on panic disorder, the first of our anxiety disorders, this is a very common disorder. Probably upwards of 1 to 2% of the population suffer from panic disorder, and it is characterized by recurrent, unexpected panic attacks. Now, what is a panic attack? A panic attack usually is a experience of intense anxiety, which lasts usually from several minutes to about a half hour or more. Alrighty, individuals who experience panic attacks may experience one or more in a given day, sometimes every day, sometimes every few days. One of the things that is characteristic of panic disorder is that it often is not related to a specific stimulus cue. Yeah, it often just comes out of nowhere. It can be driven by stress. Yeah, um, social work factors and so on. But the thing that makes panic disorders particularly unpleasant is its unpredictability. Yeah, that it just seems to just hit someone at any time, at any place. Yeah, and the anxiety, the intensity of the anxiety cannot be stated strongly enough. Yeah, very often people will feel like they're about to die, that they're having a heart attack, that the heart is racing so quickly, that the fear is so intense that it's not uncommon for those who suffer from panic disorder to take themselves to emergency rooms because they literally think they have the experience that they are going to literally die. All right, because of their internal state and heart palpitations and so on. Okay, now the duration of to be diagnosed, you need to be experiencing this for about a month. It has to cause social occupational functioning or distress. Yeah, because sometimes people may be able to function adequately in work and socially, but they have panic attacks. Yeah, it's enough that it causes them distress. Alrighty, and here are some of the common disorders to differentiate from panic disorder. You have to make sure you're not dealing with someone who's suffering from, let's say, a substance abuse or some other physical disorder, OCD or PTSD, or obsessive compulsive disorder, which we'll talk about later. Um, I every over the course of my close to 20 years of teaching, I've had a handful of students come up to me and tell me that they suffer from panic disorder, and that they're excused. And if I would excuse them if they just stood up in the middle of class to, step out so that they can gather themselves. Yeah, I remember one male student told me that he would do that, or if in the middle of class he just seems to close his eyes and seems to be sitting still, that I shouldn't take it, misinterpret that as his napping in the middle of lecture. Which, yeah, as a side, fine by me. That's your money. um, but if you want to nap while people are surrounding you, that's fine. That's your business. But that no, he was saying he wanted to make clear that he wasn't taking a nap, but that he was just meditating, doing some deep breathing exercises to calm himself down, and very often that would mute or prevent a panic attack coming on for him. He said prior to that, and that he had learned that in a few sessions of psychological treatment, individual therapy. Um, Prior to that, he would just have full blown out attacks and have a very incredibly difficult time in like class situations. But yeah, but after going through a few sessions of cognitive behavioral therapy, he learned some strategies by which he could control the panic attacks. Yeah. And very often, even, this sounds similar to our prior discussion about PTSD. And this actually goes for many disorders. Yeah. That the effect of psychological treatment may be the complete disappearance of those symptoms forever and ever and ever. Some people are fortunate that way. But for many individuals who suffer from a mood disorder, anxiety disorder, very often effective, successful treatment doesn't mean that they will never ever have those symptoms or problems again. Just like it's almost like saying human beings not having emotional reaction to things. I don't know if that's a real good treatment goal. That people not get nervous or never ever get nervous or never ever get sad. But if they have those experiences, it doesn't necessarily have to result into a full blown panic attack or full blown major depressive episode. Yeah, that these sad moments or anxiety provoking moments can be really modified, reduced. Yeah, but never completely disappear. Now, what is the cause of panic disorder? Well, what's a one theory posits that that many of us um, are genetically predisposed to be sensitive to certain sensations, yeah, or dull to certain sensations. For example, some of us might have greater acuity with vision, might be more sensitive to brightness. Some of us may have greater sensitivity to sound, might have better hearing. Well, along those lines, another sensation are sensations of internal cues, such as heart palpitations or tightening of muscles and so on. And just like, more sensitive vision, more sensitive hearing, that maybe some of us just have more sensitive, um, uh, are more sensitive or aware of our internal body cues. But for some of us who have that, it's just, it's not that bad. We interpret those cues as, oh, well, I'm just feeling nervous. But that for others, because as a function of their sensitivity to these cues, like someone who has really good vision or is particularly sensitive to bright light, that they may experience those cues more intensely, but on top of it, may make cognitive attributions about those sensations, which lead to a vicious cycle. Cognitive attributions may be, oh, I'm feeling this intense heart palpitations because I'm in a bad physical state, or I'm going to have a heart attack, or that, and then saying other things to themselves like, I can't take it. This is I can't, that I can't stand this, that I need medical emergency help, and so on. And then you get this vicious cycle going on between what people are saying and then increasing the physiological symptoms and then so on. Yeah. Um, where they get a greater production of adrenaline and noradrenaline. And when that happens, right, the physiological responses are greater, which they've already felt more sensitively. And then it becomes just this very difficult emotional circumstance and becomes a panic attack. Okay, with increased heart rate, rapid breathing, and sweating. And some individuals who suffer panic attacks have described, just breaking out into a not cold, but breaking out into a sweat. Yeah, sometimes almost their shirt just being drenched in sweat because they're just so terrified because the anxiety is that intense. Okay. Common treatments include, well, the first go-to really are benzodiazepines, anti-anxiety medications, sometimes referred to as anxiolytics. They include things such as Xanax. Valium may be used in some cases, but Xanax is probably the most common for panic disorder. Valium for just general nervousness and generalized anxiety, but Xanax in particular for panic disorder. Okay. Antidepressants may be used as well because, as mentioned before, probably mentioned again, depression and anxiety often are correlated. Yeah, and there may be underlying um, similar or concurrent, not similar, but concurrent physiological neurochemical processes at play too. Okay. Also, for the psychological treatment, it usually involves helping the person reinterpret their physiological state. Yeah. Um, so part of what happens, part of the work in the individual session, some part of it very commonly is to induce, oddly enough, those symptoms. Yeah, by having the person like blow in and out very quickly and deeply into a paper bag, and then that inhalation of carbon dioxide, yeah, starts uh, leading someone, inducing someone to have panic, anxiety symptoms. Yeah, but in the room now in this kind of controlled setting and with the guidance and the coaching of the individual therapist, while the person is having those symptoms, yeah, the person starts practicing things that they can say to themselves to calm themselves. Yeah, very real reality based things like my heart is increasing, my heart rate is increasing, I'm starting to sweat, but, this is just part of that physiological reaction that I may be more attuned or sensitive to or aware of. Yeah, based on my own physiology. It's not the end of the world. It's an unpleasant feeling. It feels like crap, but it's something I can stand. I'm not going to die. And there are things I can do to reduce it. Maybe not make it like deep breathing exercises, deep muscle relaxation, removing myself momentarily from a situation. Yeah, because one of the things that can also happen is if someone's having a panic disorder and they're around people, they may be particularly um, conscious of people noticing them, or whether people are noticing them or not, or being concerned about it, having social apprehension, which doesn't help the anxiety. So if they just walk over somewhere where there aren't as many people and just like kind of pause and look out the window and try to relax, that's absolutely fine. And that can help too. Okay, so that there are things they can say to themselves and behaviors that they can do to modify, and very often with practice prevent panic attacks from occurring. Yeah, but not anxiety symptoms. Yeah, for most people, most of the time, they will always have anxiety symptoms. Well, like we all do, we all get anxious at times. But the idea that the stuff that comes out of nowhere, that for those who suffer from panic disorder, they may almost always experience that. These kinds of anxiety just coming out of nowhere. But now they have a whole bunch of tools that they can use to address it. Yeah, and have manage it better. Alrighty, phobic disorders. Now, phobic disorders, I think many of you are quite aware of. That refers to a marked or persistent fear that is excessive, cued by the presence or anticipation of a specific situation. Yeah, so it could, number one thing is public speaking for people. Yeah, in terms of I think unpleasant events, in surveys, what is it? You often hear people saying public speaking is even worse than having to deal with the death of a loved one. I mean, that's awful, but for many of us, public speaking is even greater than that, right? We try to avoid that at all costs. Um, and it could be public speaking, could be a dog, could be a cramped place like an elevator. Yeah, all of these things um, fall under characterized phobic disorders. Yeah, some kind of stimulus cue, unlike panic disorder, right, doesn't require a stimulus cue. Here a specific stimulus cue, right, produces anxiety response that is in excess of what is that is excessive or unreasonable. All righty. Um, so if someone, if you see a really, huge dog growling at you, it probably is reasonable to feel a little nervous and walk on the other side of the street. But, if a little chihuahua is barking at you and you're almost getting a panic attack, you're running across the street. I mean, chihuahua, right? You can just probably, drop kick the chihuahua across the street. But, if you feel you have to run across the street because the chihuahua's going at you, that's probably classic dog phobia. All righty. Not meaning to laugh at the dog phobics. All right. Phobias are incredibly common. Anywhere upwards of 10% of the population suffers from some kind of phobia. Needles, dogs, I guess you could have cats. You don't hear cat phobics very often. Heights is another big one. Enclosed spaces, as I mentioned before. Okay. Um, and the thing is with a phobic disorder, the person recognizes that their response is excessive. Yeah, like for example, fear of elevators, so they go to the 20th floor by taking the stairs. Not uncommon. Yeah, at one of our old buildings, which was called the MP, M as in Mike, P as in Peter, MP building. Yeah, I had a few students tell me that they would often take the stairs. I mean, we're only 4 floors, 4 flights, but not 4 flights, 3 flights to the 4th floor. And but they said they would always do that as opposed to taking the elevator. Yeah, that for some reason, the minute they entered an elevator, it was more of the claustrophobic nature of it. Yeah, being in an enclosed space where they felt like for a moment, which is true, you are in an enclosed space where for a moment you have no control, right? The doors are closed and you're just stuck there. But that for some people, that would just be too much and they couldn't take it. So they would walk up 3 flights of stairs. Okay. But to be diagnosed, yeah, it has to interfere with social occupational functioning. So a lot of people have phobias, but may not be diagnosable in that. And this is why a lot of people aren't diagnosable, is because they find ways to avoid it. Okay. They just walk across the street if there's a dog, climb the stairs, and so on. Okay. But if it affects one's work, right? Like they're about to get fired because of their phobia, or, they're not going out with friends because of their phobia, then, probably someone is, then, you have that criterion met and they can be diagnosed. Okay, specific phobias, persistent excessive fear of a specific object or situation. Um, so it affects lifestyle and functioning, as I mentioned before. It has to, for specific phobia. Okay, so this is how to meet just generally phobic disorders. But for to be diagnosed with a specific phobia, as I mentioned before, social occupational functioning, and you got to present symptoms for about 6 months. Okay. You also want to be sure it's not one of these other diagnoses like substance abuse. Agoraphobia we'll get into a little later. It's not a specific phobia. It's a completely separate um, disorder itself. Yeah. Specific phobias, again, would be things like of dogs, height, enclosed spaces, and so on. Alrighty. Uh, Separation anxiety disorder is a different diagnosis from specific phobia. You also want to be sure it's not OCD or PTSD. And here are the common types of phobias. All right, animal, natural environment, situational, let's see, blood injection injury, quite common, and a number of others. Yeah, here are some of the other ones of animals: bees, spiders, and so on. Mice, natural environment, star. The star, interesting enough, stars appearing can freak out some people. You don't hear that one very often. Rain, you don't hear that one very often, but it can. Wind, let's see, blood disease, needles, injury, pain, and other situations in closed spaces, travel, bridges, and empty rooms. Okay. And the thing is, when you look at this list, it seems silly to most of us. Well, maybe not all of us, because 1 out of 10 of us have some kind of phobia. We just might not be diagnosable. Yeah. So many of us do. And later on, when we meet face to face or in Zoom, we'll probably have a little bit of a discussion about this. Okay. With that, let me stop here to just take a quick break. Alrighty then, let's continue our discussion. Thank you for that moment. And social anxiety disorder. Okay, now this is a disorder characterized by the fear of being observed, evaluated, judged by others. Yeah, so it's not just being around people. Alrighty, it's the idea that while you're being around people, they are critiquing you, evaluating you. Okay, and that related to that, that one will act in a manner that will humiliate oneself, embarrass oneself. Okay, that one will, for example, have a panic attack or because of their feeling shy and nervous, that everyone can see that and are judging them for that. Okay, very common disorder. Maybe 2 to 3% of the population suffer from this. You need to be demonstrating these symptoms for about 6 months, and again, it has to be interfering with social occupational functioning. Okay, again, if you're doing well with friends, dating, and work is fine, so you have these fears, you're not diagnosable. But if they're keeping you from, making friends and going to work meetings and so on, yeah, then you may be diagnosable. And again, here are some of the disorders to distinguish from social anxiety disorder. Alrighty, and make sure it's clear in your mind that this is not like a phobia. Okay, it's not a phobia of people. It's separate. Yeah. Um, with the phobias, just think like just the stimulus, just the cue itself is enough, right? Seeing the dog, seeing the elevator, seeing the needle. A social anxiety disorder, it's just not seeing people. All right, it's not people phobia. If it was like that, um, then maybe it could be a phobia. But it's this larger phenomenon of feeling judged and evaluated, and also feeling that um, that they're acting in a way that they act in a way by being shy or quiet or nervous, that's producing this negative, what's perceived to be negative evaluation by people, whether that's occurring or not. Yeah. Um, so with that, let's move here. The other disorder is agoraphobia. All righty, separate from one of the specific phobic disorders. Okay, it is characterized by a fear of being in open spaces. Okay, like in a parking lot or a large outdoor or indoor, for that matter, mall, and in being in those situations and alone and being alone. Okay, it's alongside of that fear. Again, it's not just of those situations, but it's about having fears of losing control. Yeah, of just having such intense panic, and it often occurs with panic attacks. Yeah, it often the etiology of this disorder is often characterized by being preceded by a panic attack. Yeah, which occurs at a mall or some outdoor place, and feeling when they had that panic attack, let's say in the parking lot on their way to their car, that they were having a heart attack and that no one was going to be able to help them. Alrighty. Um, and one of the things that's kind of interesting with agoraphobia is that it's often, unlike panic disorder, right? When people have panic attacks, even when they're with people, they're with friends, they're with family, they can have a panic attack. Okay. And the family member or friend being there usually doesn't stop it. With agoraphobia, it's more common that when people are with someone they know, they don't have those they don't have the panic attacks or intense anxiety that makes them fear being out in the open place. That's what agora is. It refers to the marketplace. Um, that's what that prefix to phobia represents. It means the marketplace, or in this case, fear of the marketplace. But it's just not the fear of the marketplace per se. It's the fear of being helpless, not having any control. Okay. And very often, again, those who suffer from this, when they're with a friend or family member, they usually don't have that same intense anxiety, and they can go about um, shopping or in public places and so on. Agoraphobia can also be characterized by someone just clearly just by staying indoors, staying at the home, staying in an apartment, because that's where they feel safe and in control. Or if they do feel panicky, they know that no one else is going to see them, that they can, go to bed or lie on their sofa to calm themselves down, and no one will see. Okay, but it isn't just staying inside. It's really this phenomenon of fearing the I guess they are clearly related, but it's not just wanting to stay inside and play video games all day. It's this fear of being out and about and being in a situation where one may be in danger. Yeah, not of being attacked, but because of having a panic attack, that they will not get medical services or assistance that they need, or embarrassing themselves. Yeah, I think I recall one or two cases where people reported feeling that they would defecate themselves because they were so nervous. right? So the idea of, soiling their pants in public was the intense fear. Now, again, here's the magic number 6 months for how long the symptoms have to persist before someone can be diagnosed suffering from agoraphobia. And also, you need to demonstrate social occupational functioning or distress. Again, you might do fine with work, and maybe family and friends are willing to, um, socialize with you, uh, as you're struggling with this, or you don't struggle with it because they kind of help you out. But that's not, but you don't need to have social or occupational functioning. Just being distressed about it is sufficient. Okay, and again, we have the kind of similar grouping of other diagnoses you need to consider before assuming or ruling in that it's agoraphobia. Okay. Now, agoraphobia may have been learned. What may have been learned, and one of the best theoretical frameworks for understanding agoraphobia is the classical conditioning model. Actually, for a lot of the anxiety disorders, yeah. But as we're on agoraphobia, let's talk about how to apply the classical conditioning framework. Yeah, you can see that. Well, first of all, having a panic attack is often something that's genetically one may be genetically predisposed to. Some of us more than others. Yeah, we all have different genetic predispositions, right, for muscle mass or gaining weight or losing weight, and with so many behaviors, and one of which may be being very attuned to physiological responses like increased heart rate, muscle tension, and so on. Yeah. So having that unconditioned stimulus, yeah, the thing that was driven by your genes or your DNA that wasn't learned, it just happens, right? May be conditioned to a conditioned stimulus like the agora, the marketplace, being outdoors, being out of your home. Yeah. And you only need a couple pairings of that for the agora then to be a conditioned stimulus for the conditioned response of fear and avoidance. Yeah. And once that kicks in, yeah, you just have this repetitive operant conditioning learning going on where every time someone feels anxiety as they approach the door, they decrease that anxiety by closing the door and going back to their room or back to their computer. And then when an anxiety disappears, that's a powerful negative reinforcer. And it's reinforcing remaining in home behavior. All righty, but that's super powerful reinforcer to keep someone inside and possibly develop an agoraphobia disorder. Okay, so what are some of the psychological treatments for panic disorder, for phobias, for agoraphobias? Okay, now all this, I'm just going to be speaking about a general framework, but clearly has to be attuned to the particular diagnosis. What's the stimulus and the characteristics of the anxiety um, response. Okay. Also has to be clearly, maybe I'm stating the obvious here, to the particular, physiology, behaviors, cognitions, thoughts that the individual is manifesting. Okay. So there's no, one size treatment fits all. I'm just talking about a general framework, which has to take, which needs to be adapted to some of the things I just mentioned. Okay. Now, as far as psychological treatments are concerned, there is a ton of research to support the use of cognitive behavioral techniques, in particular, systematic desensitization. Okay. That's been around for now, over 50 years. Gee, maybe even if you count the 50s when a lot of the original by James Wolpe, um, those were who is the big figure in terms of developing systematic desensitization. I think he actually started his work in the mid 50s. So it's been with us for close to 70 years now. Yeah. And systematic desensitization is characterized by exposing the person to gradual increasing amounts of the conditioned stimuli that brings on the anxiety. But when doing that, yeah, you with systematic desensitization, you train the individual by way of um, um, muscle relaxation, deep breathing, other meditation exercises to have a different unconditioned, to have a counter, to counter condition the prior classical conditioning, right? So the prior classical conditioning may have been associating the unconditioned stimulus of the panic symptoms with the conditioned stimulus of the agora, which now produces the conditioned response of the anxiety, right? But to counter condition the anxiety with relaxation, deep muscle relaxation, or decreasing of muscle tension, and so on. Okay, so when they are exposed to stimulus, they prior to being exposed to stimulus, they learn these techniques and strategies, and then when exposed to the stimulus, they utilize those strategies to counter condition the prior learning, right? To undercut the anxiety that they're feeling every time they experience the stimulus. So, for example, with agoraphobia, it may be having the person walk to the door, and then as they start approaching the door, already with that one small step, they're feeling anxiety. Well, then the psychologist would coach and assist them in counter conditioning that response by using meditation, deep breathing, and so on. Yeah. And only at the point where they can approach the door with a significantly reduced amount of anxiety do they do the next step, which might be opening the door, and then repeating that same process until they can open the door with a significantly reduced amount of anxiety. And then the next step being stepping out the door. Then the next step being walking 10 feet from the door, 15, 20, and so on until the patient or client can reach the objective uh, behavior that's desired, yeah, which is maybe going to work or visiting a friend and so on. Alrighty. Now the exposure can be either actual or imagined. Yeah. And a lot of studies show that even if you imagine the stimulus, that people can make really significant gains. Alrighty. Now the exposure could be a gradual, as I mentioned before, through systematic desensitization, or it can be done by way of flooding. And flooding is, I would analogize it to any of you who are taught swimming by a family member who just threw you into the deep end of the swimming pool, and then you just kind of dog paddled your way out. Just because most of us, not everyone, that's why it's not the smartest swimming teaching technique, but most of us are able to kind of figure how to keep our heads above the water. Okay, we're not swimming like Olympic swimmers or anything, but at least we can like dog paddle, or as we're screaming and keeping our head above the water. That's the idea with flooding, that the exposure to the conditioned stimulus, it doesn't happen in baby steps. You just throw the person in. So it's about just walking onto the airplane or stepping out if you have a flight phobia, or if you're agoraphobic, let's just start walking out of the house now. Alrighty. Again, this could be done either by way of visually, by way of imagination, or in vivo, meaning in the real world. Okay. We'll skip these. Let's talk about generalized anxiety disorder. And with that, if you just allow me a moment. Okay, thank you for your patience there. And let us continue. Generalized anxiety disorder. Well, it's kind of like what the term suggests. It is about being anxious about everything. Alrighty. And actually, let me get out of here. Oops, sorry, I forgot to pull up the screen there. Okay, my apologies. So generalized anxiety disorder is about being anxious about everything. Okay, so it is. Let's see. What uh, it's about being anxious about work, relationships, doing your taxes, your body weight, everything, just being a little, not a little, but anxious, generally anxious about almost everything. Okay, just a lot of worry. It's associated with these symptoms: sleep disturbance, muscle tension, decreased concentration, also irritability as well. Yeah. Now, let's see. Again, to be diagnosed, you need to have impairment in social occupational functioning. Okay. And you need to have suffered from symptoms for about a 6-month period. Alrighty. And this is something that either interferes with social or occupational functioning, but to be diagnosable, you could be doing fine in those areas as long as you're suffering from distress, if it's something that's upsetting you. Yeah. And when it comes to college students and research in terms of what's the most common diagnosis in college counseling centers, no big surprise, this is among the top diagnoses: generalized anxiety disorder. Okay. Now, let's talk about obsessive compulsive disorder. Okay. OCD, which I think probably a number of you are familiar with, is characterized by obsessions and compulsive behaviors. Now, the obsessions refer to constant, frequent, uncontrollable beliefs that tend to, you know, um, come out of nowhere. Well, no, they're brought on, but I'm sorry, scratch that, not come out of nowhere, but frequently occur and tend to disrupt one's functioning. Yeah. Now, they are often brought on by specific stimuli. Now, there are a number of different OCD, obsessive compulsive disorder types. Yeah. Some are about cleanliness, some are relatively superstitious in nature, right? Thinking that if they step on a crack on the ground, they're going to hurt their mother. It's something bad's going to happen to their mother. Some may do with obsessive thoughts about uh, lurid sexual behaviors, or sometimes violent behaviors against others. And when people have these obsessive thoughts, these frequent thoughts that just seem to, enter into their consciousness and for which they have little control, the thing that gives them control is compulsive behavior. Okay, so let's just say someone enters a bathroom and they think, oh, it's dirty, there's germs everywhere, and so on. Right? A compulsive behavior may be to move the bottles in a certain way, or wipe the bathroom sink with some kind of sterile wet cloth. Alrighty. Another one would be if they touch something, right? They immediately think that their hands are, covered with viruses or filth and so on. And that obsessive thought, yeah, about violence, sexual behavior, disease, and so on, or superstitious stuff that, because they stepped on a crack, something bad is going to happen to the mother. Those obsessive thoughts are only controlled or muted by the compulsive behavior. So washing their hands, putting things in order, counting. Sometimes it'll be counting behavior, very common. Sometimes it will be, making a certain noise with their mouth, like a clicking noise, or something, or there's just a wide variety of kinds of compulsive behaviors, ritualistic in nature, that seem to help people, not in a good way, control their obsessions, right? So by either clicking their hands, or making certain clicking noises, or counting, or avoiding stepping on cracks, or washing their hands every 5 minutes, they can control these obsessive thoughts. Okay. Again, it falls into that classical conditioning framework and operant conditioning. Yeah, that certain stimuli are just associated with intense feelings, and then we have avoidance behaviors. So behaviors that can help the person, in this situation, not avoid, like let's say in agoraphobia, avoid being outdoors. So you just close the door and you stay inside. But in terms of behaviors that mitigate, reduce the obsessive thoughts of washing the hands every 5 minutes, makes someone feel like, oh, my fear, that intense anxiety that my hands are filthy and that I'm going to die from a disease, is decreasing now. And again, avoidance behaviors, um, negative reinforcement is super powerful in maintaining behavior, can be super powerful in maintaining behavior, because when you take away anxiety, stating the obvious here, but is incredibly upsetting for people, for some people more than others. Yeah. And that's the thing, it's still kind of hard to discern people's internal subject. What do they actually feel physically? Yeah. I mean, you can measure heart rate. Yeah. And you can measure muscle tension. But yeah, but the same amount of heart rate or muscle tension, one person will subjectively experience that as like emotional pain and distress. Um, and which is just horrific or horrible for them, whereas others will experience it as, my heart's going up, my muscles are a little tense. It may be in large part what people are saying to themselves. Yeah, and that's why there's a lot of credence to the cognitive approach. That we can, if we say different things to ourselves, different words which have different associations, yeah, that we can either increase the intensity of the experience or decrease one. Yeah. Um, you know, where or to what extent is actual of the physical, kind of experience, and it's difficult, because it's like measuring pain, like from headaches. Yeah. Someone might have the same amount of muscle tension in the head, and one person will experience it as an intensely awful migraine, another will say, yeah, so my head's a little tense. you know and it may be beyond whether someone is a complainer or not, right? Because it's easy to maybe attribute or oversimplify that the person's pain is not real, that they're just saying it, or they're complaining, or maybe it is a subjective experience. And it very well is for things like migraine. And that's very not it very well. It very well is. Um, the case that migraines are just experienced, that pain is different, and that's the whole area of pain, which is beyond the scope of this discussion, but it's related to understanding the intensity of anxiety for people. Right? Here are some the content of some obsessions. You can see some of them can be kind of odd. Fears that the teeth are decaying, uh, focusing on women's buttocks, being overly kind of sensitive, aware of one's eye movements, fears that fetuses are lying in the street. Fetuses, that they're somewhere, these dead babies or the remains of these dead babies. I mean, it can sound psychotic at times, and that's one thing you certainly want to perhaps distinguish is whether someone's experiencing something of that sort. Yeah. But very often there is no psychotic process. There's only this very odd um, obsessive thought. Yeah. Fear of contracting AIDS, and so on. And then some of the rituals, I think, many of us are familiar with. And when we meet face to face or via Zoom, we'll probably go over a video, a really good video on OCD. Okay, moving right along. Body dysmorphic disorder. Okay, another disorder that's fuel generated by anxiety, and it's characterized by preoccupation with an imagined or exaggerated physical defect in one's appearance, causing a person to feel that they're ugly or even disfigured. Yeah. Let's see. So things like some might be feeling that they got too many wrinkles, so that they have to constantly get, is it collagen injections to make those wrinkles disappear, or plastic surgery, feeling that their nose is too big, too small, the lips too big, too small, and what have you. Yeah. And that people will judge them negatively based on this perceived defect. Alrighty. In a survey by Phillips and all, kind of dated, what were some of the common imagined defects among 30 patients with body, and it sounds like a small n, and generally is a small n, but for body dysmorphic disorder, this is a pretty nice size n. It's hard to get this number of patients with body dysmorphic disorder together to participate in a study. So included fears concerning their hair was most common, nose and skin, something about their eyes, head or face typically, and overall body. You can see less with lips. And then that's so with chin, but see, here are some other things that people can have be concerned about with body dysmorphic disorders. Knees. Who would think someone would be concerned about their knees? And interesting enough, there was one more person who was concerned about the legs or knees versus their face, or and so on. Even ears, go figure. Okay, and with that, yep, that ends our discussion on anxiety disorders. Yeah, anxiety disorders and anxiety-driven kind of disorders. Alrighty, with that, I thank you again for your attention, and we will meet again to talk about other disorders in the area of abnormal psychology. And with that, have a good one, gang. Take care. Bye-bye.